Good morning, we're Group B. Our group consists of me, James Bartalotta, Celine Soon, Jordan Sparks and Krystine Habel. Now, we've been presented with this case of a 15-year-old male patient whose overall health is good, with no abnormalities present in his medical history. However, he has complained of having stomach cramps recently. We were also presented with one clinical photograph showing a lateral view of the anterior two-thirds of the patient's tongue. There is a small lesion on the right side of the tongue on the dorsal surface. It appears to be regular in shape and an ulceration of 2 to 3 millimeters in diameter, with white rolled edges and an erythematous depapillated center. The rest of the tongue and mouth appears healthy from this clinical photograph. The patient has stated that the lesion has been present in the mouth for 2 weeks and is asymptomatic. Now, we've been tasked with developing a differential diagnosis for this patient's condition, as well as how we will manage the patient's condition. I'll now let Jordan explain the possible differential diagnosis for this patient.
Thanks, James. So, recurrent aphthous stomatitis presents as 3 main lesions: minor, major and herpetiform aphthous. While the presented lesion appears to be less than 10 mm in length, minor aphtha generally affects the oral cavity or non-keratinized areas such as the floor of the mouth, soft palate, ventral surface of the tongue and also the buccal labial mucosa. Minor aphthae are described with an erythematous margin and yellowish floor, and as such may suggest trauma. Major aphthae, which usually affects keratinized areas of the mouth, such as the dorsal surface of the tongue and the attached gingiva, also presents as a differential diagnosis. However, presenting as less than 1 centimeter at this stage suggests otherwise. The most helpful diagnostic feature when diagnosing RAS is a history of self-healing ulcers at reasonably frequent intervals, looking for signs and symptoms of Behçet's disease, as this also presents with RAS inside the mouth. Upon examination, a positive family history, distribution only on the non-keratinized mucosa, sharp, well-defined edges and scarring upon the soft palate, major aphthae, would make RAS a likely diagnosis. Special investigations including checking for anemia, iron, red cell folate and vitamin B12 status, as well as history of diarrhea, constipation or blood in stools is important in excluding underlying conditions. A formal examination to rule out carcinoma is paramount. Persisting for greater than 2 weeks in the mouth may suggest a persisting lesion which may require biopsy to exclude a premalignant lesion. It is therefore essential that we acquire further information from the patient and investigate as to whether there is a traumatic cause behind the ulcer. With the lateral tongue being a high-risk area of the mouth for the development of oral cancer, biopsy may be necessary, reviewing histopathology of any irregularities suggesting dysplasia, which may indicate a premalignant lesion, carcinoma in situ or of similar. Clinical presentation of median rhomboid glossitis is generally a rhomboidal shape with depapillation and atrophy in the midline of the dorsum of the tongue. It is generally straightforwardly diagnosed, and further investigation by means such as biopsy is generally only to exclude carcinoma or lacking of a definitive diagnosis. Due to the lesion presented and its location being on the lateral dorsum of the tongue, median rhomboid glossitis is an unlikely diagnosis. While uncommon, tuberculosis may present orally as angular ulcers with overhanging edges and a pale floor, but the lesion may be pale or irregular. Due to the well-defined border and erythematous base of the presented ulcer, tuberculosis also appears to be an unlikely diagnosis. Syphilis is a potential diagnosis as it may cause ulceration in the mouth. However, as always, patient history is very important, and being of just 15 years of age makes syphilis an unlikely diagnosis. Further diagnosis may be supported by serological confirmation with specific FTAABS or non-specific VDRL tests. I'll now pass on to Krystine, who will further discuss the differential diagnoses.
All right, thank you, Jordan. Trauma, signs and symptoms. Trauma ulcers generally are inflammatory, swellings, erythema, and are variable depending on cause and time of trauma. Injuries may persist for weeks, especially on the tongue, which is in our case. Patient complains of tenderness, pain in area of the lesion. Trauma to epithelium may be mechanical, chemical, or thermal, such as in foods, and may be readily identified. Accidents may also be caused by self-infliction, fictitious, such as tongue biting, after local anesthetic administration. Mechanical could include badly fitted dental appliances, sharp dental restorations, broken teeth, usually tongue and buccal mucosa are affected, graze from a harsh toothbrush. Kids may even be running with an object in their mouth and cause an injury to the tongue. Xerostomia, which may cause decreased hydration, which increases friction and can cause smooth margins to be traumatic, may be predisposed to more infections. Investigations include remove cause to see if symptoms improve, biopsy if tongue does not resolve in a few weeks. Okay, hepatic stomatitis. Signs and symptoms. They cause multiple vesicles, round scattered ulcers, and yellow slough and erythematous halo. This is different in our case because we don't have this in our picture. However, ulcers can fuse to create irregular lesions, and they could be painful and may interfere with eating, which isn't the case in our situation. Other symptoms may include fever, malaise, irritability, and vomiting. Any areas of the mouth can be affected, including dorsum of the tongue. Etiopathogenesis is herpes simplex virus, usually type 1 in young children and type 2 in older age groups. Investigations would include a smear to show viral immunostaining, and rinse titer of antibodies is confirmatory, and this is with the GP. All right, so oral signs and symptoms. These mainly affect young adults, and main areas affected are persistent swellings of the lips, buccal mucosa, and gingiva, which is unlike in our case, which is a tongue lesion on the dorsum. Further investigations in the oral cavity would also show mucosal cobblestone tags, gingival swelling or ulcers, persistent and ragged hyperplastic margins, mouth ulcers, which may also be due secondarily to folate and other deficiencies or coincidental associations, mainly may affect other parts of the GI tract from mouth to anus, but especially the ileocecal region. The general practitioner would probably do further investigation for blood stools, diarrhea, abdominal pain, and to rule out also obstructive GI problems and malabsorption. Malabsorption can also cause glossitis due to iron, folate, and vitamin B deficiency, and glossitis may cause trauma. Cause may be unknown, but is mainly associated with a gene and is frequently associated also with bacteria. Would send to GP for blood serum and ultrasound and endoscopy. Ulcerative colitis mainly affects older adults, which is different in our case because our case is a 15-year-old. Unlikely, and it could be associated with malabsorption, and this could lead to anemia due to chronic bowel hemorrhaging affecting any oral sites. Persistent other symptoms could be persistent diarrhea and frequently is painless. Etiological pathogenesis, unknown, but is associated with autoimmunity, diet, some drugs, and genetic basis. Investigation, biopsy, full blood tests, colonoscopy, and barium anemia by a gastroenterologist. Okay, celiac disease is another GI disorder. Signs and symptoms are variable ulcerations and can occur anywhere orally. Glossitis, angular stomatitis, enamel hyperplasia, and may mimic other lesions. So even though we don't have these signs and symptoms in our case, they could result from celiac mimicking these a lesion. There also may be other symptoms from a malabsorption, and this could include anemia, which can result in glossitis and cause recurrent aphthei, and up to 5% may have RAU even in absence of anemia. The etiopathogenesis is usually genetic background, and there is a hypersensitivity or toxic reaction of the small intestinal mucosa to gluten, and this is found in all forms of wheat and grains, causing villous atrophy and inflammation. Main associated conditions are Sjogren's syndrome, food sensitivities, and further investigations would include GP referral to a gastroenterologist, and they would do serum antibody screening, full blood count, stool examination, digestive absorption tests, and endoscopy. Now I hand over to James.
Thanks, Krystine. After a definitive diagnosis or working diagnosis is reached, with the help of special investigations and tests, and possible specialist referral, we can begin to formulate a management plan for this patient depending on the diagnosis that is reached. Seeing as the ulcer is non-symptomatic, the acute treatment phase is not required at this stage. However, we would try to induce healing and prevent exacerbation of the ulcerated area. If we were to treat this ulcer as a manifestation of Crohn's, celiac, or ulcerative colitis, we would advise the patient that specialist referral is required for systemic control of the disease, and the patient should be informed that when these bowel diseases are controlled, oral manifestations will usually resolve. Treatment of Crohn's disease is not curative, but is focused on management of symptoms. It would involve systemic corticosteroids such as N-Cort to reduce the inflammatory response of the intestines, or other immunosuppressive drugs such as methotrexate. In patients with celiac disease, the main treatment modality would be to cease consumption of gluten to control the inflammatory response of the GIT and thus malabsorption as a result. Furthermore, medications may be used to reduce specific oral manifestations. This could include ultra-potent topical corticosteroids such as betamethasone dipropionate or systemic corticosteroids. Through decreased intestinal inflammation, the absorption through the gut would improve, and thus vitamins and minerals such as B12, folate, and iron levels are expected to improve, which may resolve the oral ulcers associated with these conditions. If the ulcer was diagnosed as a recurrent aphthous stomatitis with no link to gastrointestinal disorders, as there are no specific cures for this disease or condition, and the fact that these ulcers will usually resolve within 2 to 4 weeks, the main goal of treatment would be to lessen any pain or discomfort that may arise, as well as to promote healing. Some of the general measures that could be used for management include dibacterol gel, which forms a physical protective barrier over the ulcer to reduce exposure to irritating substances, antibacterial mouthwashes such as chlorhexidine mouthwash or triclosan mouthwash to reduce the chance of secondary infection and to promote healing, dietary supplements such as vitamins and minerals, for example vitamin B12, iron or folate, to resolve any dietary deficiencies. Stress reduction techniques may be employed, such as informing the patient to do some physical exercise, ensuring they get enough sleep, and also improving their diet. If this ulcer becomes symptomatic or is persistent, we may consider prescribing some medications for its management, such as topical local anesthetics, for example lignocaine or benzocaine, or topical corticosteroids such as hydrocortisone, to reduce any inflammatory response which may be causing this ulcer. I'll now pass on to Celine, who will further discuss the management of this patient.
Thanks, James. For syphilis, penicillin remains the drug of choice to treat all stages of syphilis. Primary, secondary, and early latent diseases are treated with a single intramuscular dose of benzathine penicillin G. In patients with primary syphilis, doxycycline have shown a high serological treatment success rate. Furthermore, individuals that are allergic to penicillin could be prescribed doxycycline or tetracycline as an alternative. Treatment of ulcerated lesions varies depending upon size, duration, and location. With ulcerations that are induced by mechanical trauma or thermal burns from food or medications, it is essential to remove the cause. The lesions should then typically resolve after 10 to 14 days. Using a soft mouth guard could be an option to prevent further trauma to the ulceration or to prevent ulceration from recurring in that area. The use of a sedative mouth rinse such as benzodiazepine, application of topical corticosteroids, and topical anesthetic are viable options to manage any pain that may occur. Additionally, 0.2% chlorhexidine mouthwash or saline mouthwash helps alleviate pain temporarily. Tuberculosis. Most young individuals with tuberculosis can be treated with isoniazid and rifampin for 6 months along with pyrazinamide for the first 2 months if the culture from the source case is fully susceptible. Isoniazid tablets may be crushed and added to food. Isoniazid liquid without sorbitol should be used to avoid osmotic diarrhea, which can cause decreased absorption. Rifampin capsules may be opened and the powder added to food. If rifampin is not tolerated, it may be taken in divided doses 20 minutes after light meals. Carcinoma in its early stages presents with painless ulcers. However, at later stages, it becomes painful. During this stage, we could use supportive measures to relieve the pain. Supportive measures for painful ulcers include topical anesthetics such as lidocaine and analgesics like single-agent benzodiazepine hydrochloride. If systemic pain is present, it is often controlled with opioids such as morphine. We would also refer them to a specialist for management of the malignancy. Other treatments for carcinoma are surgery, chemotherapy, and radiotherapy. Medium rhomboid glossitis is commonly associated with oral candidiasis. Therefore, antifungal therapy such as imidazoles, triazoles, polyenes is indicated. Additionally, replace any toothbrush or any other oral devices which may cause reinfection. It is also vital that they maintain good oral hygiene by regularly visiting their dentist, correctly brushing their teeth, and using chlorhexidine mouthwash for its anti-plaque and antifungal properties. For oral herpes, a topical anesthetic such as viscous lidocaine may be prescribed to relieve pain. Topical antivirals such as acyclovir is also prescribed. Oral or intravenous medication does exist for herpes, but is not recommended for people with a normal immune system. It is used only for people with weakened immune systems, infants younger than 6 weeks, or people with severe diseases. If fever or muscle aches are present, NSAIDs may be used. In conclusion, from the information and clinical image provided, there are numerous possible differential diagnoses for this 15-year-old patient. We have narrowed our differential diagnosis down to traumatic ulcer, recurrent after stomatitis, gastrointestinal disorder, and syphilis. Further investigations such as the history of lesion, i.e. whether the lesion is a recurring lesion or a new lesion, dental and social history, clinical examination, and additional tests are needed to come up with a definitive diagnosis. Additional tests are as listed on the slide. As dental clinicians, we need to ensure the patient's systemic health is treated at the same standard as their dental health. Early detection of diseases is essential for a better prognosis and as well to ensure a healthy mouth. Therefore, management and treatment will result in patients' comfort and affect their overall well-being. Thank you for listening to our presentation.